Good afternoon, everybody. The Ron Hubin case has raised a number of questions concerning the challenges facing medical underwriters when pricing structured settlements. And we have two very, very special guests today. The first is Rosemary Brindamour, who's the Chief Medical Underwriter for John Hancock Life USA. Rosemary, how are you doing today?
I'm very well, John. Thank you.
Excellent.
And I appreciate you letting us join you today.
Excellent. We'll be right back to you in a second. And we also have Dr. Robert Shavelle. Dr. Robert Shavelle is the Technical Director of the Life Expectancy Project in San Francisco. He's also a Fellow of the American Academy for Cerebral Palsy and Developmental Medicine. And he's been the author of over 75 studies in medical literature. So, Rosemary, let's start off with you. Could you tell us, I mean, you've read the Ron Hubin case. Tell us about what your thoughts are and and we'd like to understand you as a chief medical underwriter of one of the finer life insurance companies underwriting structured settlements. Can you tell us a little bit about some of the challenges that are faced with the persistent vegetative state versus locked-in state?
I would be happy to, John. I think first, understand the challenges. One must distinguish between the persistent vegetative state, also known as PVS and often seen abbreviated like that, and a locked-in syndrome. With PVS, it usually occurs due to external trauma to the brain. It's also known as a traumatic brain injury being the cause. You'll also see it written as a TBI in a lot of times in the medicals. A persistent vegetative state also can be due to the lack of oxygen to the brain, known as anoxia or hypoxia, due to, for example, like near drowning or near suffocation, cardiac arrest, or a medical error. The condition is considered a long-term condition after about 1 month of being in a persistent vegetative state. And it involves the upper portions of the brain, and the lower portions are spared. Usually the individual is someone who is unresponsive to any external stimulus and is unlikely to achieve any higher functioning other than what's seen within the first 6 months. It usually involves no purposeful activity or cognitive abilities, and many emerge within a few weeks, and the younger children have the chance of recovering better than adults. Adults, there's a 50% chance, where with children it's a 60% chance. Now, it's important to remember with the persistent vegetative state that recovery of consciousness may occur without functional recovery, but you've got to have that consciousness in order to regain any functional recovery.
Okay.
Recovery may not it doesn't level off until about 12 to 18 months, which is different than with the locked-in syndrome, which refers to...
Now, let me just ask you a question. So,
Sure.
Since many people in our audience are lawyers, judges, structured settlement professionals, and perhaps injured parties themselves, so when you're dealing with, if you're facing a claimant who submits medicals who is in a persistent vegetative state versus a locked-in state, what are some of the criteria that you look for?
We look for the date of the injury versus the date on the medicals. We look to the mobility of the individual. We look at the neuroimaging studies that have been completed to see what the brain activity is doing. So that helps us to differentiate between the persistent vegetative states and the locked-in syndrome. However, we are kind of at the mercy of what the physician has written when we do our rating. So that's a challenge in itself to be able to say, is this person actually in a persistent vegetative state versus the locked-in syndrome?
And perhaps Dr. Shavelle, you could weigh in as well. I would imagine that you've got the persistent vegetative state, locked-in state, and you have the Hubin case where this person was, I believe it was misdiagnosed as a persistent vegetative state, and then it turned out that it was a locked-in state. I mean, how do you, as an underwriter, is there any way that you can guard against some type of misdiagnosis like that? I mean, because I would imagine that it would have an effect on the underwriting results.
That's a very interesting question in itself, and it's a very difficult one for me to answer because, like I said, we are at the mercy of what we are given for medical information from either the broker or from the actual individual submitting the medical information to us. Here, actually, the new neuroimaging studies have helped diagnose him correctly. So this in itself is a new medical trend and is very helpful in distinguishing between the persistent vegetative state and the locked-in syndrome because with the persistent vegetative state, a lot of times you don't have any cognitive ability, where with the locked-in syndrome, you're going to find almost normal activity sometimes, and that would help differentiate the diagnosis.
Now, does in terms of the persistent vegetative state, locked-in state is a very interesting thing. But are there other areas such as quadriplegia, where you would normally in the past years think this would be a high-rated age type of a case? Have there been any changes because of how do you as an underwriter account for medical developments, improved medical developments, or the contemplation of future medical developments?
The rating itself would be dependent upon complications. Most locked-in states or persistent vegetative states don't die from the brain injury. They end up dying because of complications. Mm-hmm. So when we start seeing somebody who's having frequent pneumonias, they have a tracheostomy or gastrostomy tube in, recurrent urinary tract infections, chronic pressure ulcers, and a lot of contractures. These all have a tendency to increase the risk of infection. So we would look at that a lot differently than we would somebody who is a quadriplegic but yet functioning.
Dr. Shavelle, would you like to weigh in on the subject?
Certainly, thank you. There is, in fact, a large scientific and medical research literature on this topic, and by the topic I mean the survival of people in the vegetative state or people who have locked-in syndrome.
Could you tell us a little bit more about that?
Yes, that literature shows that the critical factor is motor function, gross motor function, skills like walking and rolling over, and then if people who can't do that, what would be important would be the mere ability to lift the head when lying on their stomach. Certainly there's often a big focus on cognitive function, or the ability to speak and understand, and that's evident in the case of Ron Hubin. That's fully understandable, of course, because this relates to the quality of life for both the patient and the caregiver. But with respect to the quantity of life, or the life expectancy, the ability to communicate is not a major factor for survival. That is, the medical research data shows that survival is similar, for example, in the vegetative state, where the person has no awareness, and the locked-in state, where cognitive function is fully preserved.
Do you foresee any challenges? Let's just go off the subject of the persistent vegetative state, locked-in syndrome, and let's talk about, for example, because we run into a lot of situations where people are paraplegics or quadriplegics, and as I mentioned before, I've been in the industry for 20 plus years, and I remember a quadriplegic years ago used to be an automatic 20 plus year age rate up. Do you see with stem cell experiments and other things, do you see that these will present challenges to medical underwriting for structured settlements?
I'll let Rosemary answer the issue about structured settlements, but in terms of the survival data, certainly there has been a major improvement in survival over the past 50 years of people with disabilities. Improvement in cerebral palsy, traumatic brain injury, and spinal cord injury. But over the last 20 years or so, it's been fairly flat or level. There have been great improvements in the early period, the first 1 or 2 years post-injury. So more people are surviving now, those critical first few years, than used to. But after the first few years, there hasn't been much of an improvement in life expectancy.
Okay.
Which is to say the life expectancy today is just about the same as it was 10 or 15 years ago for someone with quadriplegia.
Oh, that's interesting.
And I would say the same thing, Robert. I believe that there really hasn't been enough done with stem cell research yet to provide an increase in life expectancy at this point.
So it's not.
Also,
I'm sorry. Go ahead.
I was going to say also, it seems like the higher the level of the spinal cord injury, the worse the outcome is.
What the evidence shows is that for a given degree or level of disability, there hasn't been a change. But the advances in medical care and treatment have, in fact, changed the level of injury. So the level of injury is not as severe now as it used to be for a similar initial insult.
Okay. So it would really take some type of dramatic improvement or dramatic conclusions related to the stem cells in order for there to be a dramatic effect on rated ages, for example, for quadriplegics.
At this point, I believe so.
Okay. Okay, that's some of these topics are timely. We some of our readers read this stuff in the news, read the information in the news, and it's certainly a natural question to ask. Well, do either of you have any other further comments on this? We certainly appreciate your input. Do either of you have any questions to wrap up?
I would just, in closing, like to suggest if somebody is going to submit information for a rated age on a brain-injured person, that they consider that they submit to us like the date of injury, that the medical information, that they're going to get a much better rating if the medical information is 12 to 18 months after the injury, and that the neuroimaging studies and clinical testing that has been done be included with their information, and also the current functional abilities of the individual, the feeding capabilities of the individual, whether there's a need for the trach or a ventilator, and their past medical history. Submitting that information will affect the outcome on the rated age.
Okay, great. Thank you, Rosemary. And Robert, do you have any other comments?
Yes, just anecdotally, we know that Mr. Hubin was injured at age 20, and amongst people injured at age 20 and injured as he was, similarly disabled, the life expectancy is about 11 additional years. Obviously, he survived much longer, 23 years. But that just demonstrates the point that life expectancies are averages. They're not predictions of actual survival times. So
right.
People can live longer or shorter.
Yeah, I actually am familiar with a case in New York where a gentleman had a particular insult related to a misplaced tube going down the wrong way, and he was in a persistent vegetative state, and I think the particular injury happened in 1983, and the gentleman is still living. So in that particular situation, that's another example of something. It's a person who's lived far longer than what people initially predicted at that particular time. Well, thanks to both of you. My guests were Robert Shavelle and Rosemary Brindamour. We really appreciate your time, and thank you again.